So now let us start with the first topic, that is the alcoholic hepatitis. So in case of the alcoholic hepatitis, what is a very important thing that is very commonly being asked is the scoring system, right? So you have like PELD score, you have MELD score, like you have child pug score, and multiple scores are there, right? So this is one thing. So this is one thing that will be asked very commonly. Yes, please answer this question first. Which of the following is not a parameter used in the PELD score? Age of the individual, serum creatinine, albumin, INR. Right. So please remember, in case of the PELD score, the component that will not be there is your serum creatinine. Actually, the options are reversed, but please remember, it is the serum creatinine which is not the component of the PELD score. What exactly is your PELD score? It is pediatric end-stage liver disease. It is pediatric end-stage liver disease. So what are the parameters that you have in case of the PELD score? Like you have the bilirubin, right? Then followed by that you have the INR, then you have the albumin, then you have the age of the individual, then you have what is called the growth failure. Okay, so these are the components that you have in the PELD score, but creatinine is not the part of the PELD score. So, but whereas the creatinine, it is a part of the MELD score, that is model for end-stage liver disease, right? Now, I'll just show you one table which is containing all the scores, right? And this is very, very important stock question for your exam. What are the components of the MELD score? MELD score components are bilirubin, INR, and as well as the creatinine. What are the components of the MELD sodium? In case of MELD sodium, along with bilirubin, INR, and creatinine, you also have two more components, that is serum sodium and as well as the need for kidney dialysis, that is MELD sodium. PELD score just now I was discussing. And another important score which is very much useful in case of the alcoholics or the alcoholic hepatitis is like the child pug score. The parameters are bilirubin, INR, albumin, ascites, and as well as the asterixis. So I'm telling you, without revising this table, don't go to the exam at all. Without revising this table, don't go to the exam at all. This is one of the very, very important stock question. Either they will ask you the MELD score or they will ask you the child pug score and what are the parameters that are being asked. Okay, right. Now, what is the first important topic that I'll be doing as a quick revision is the alcoholic hepatitis. Okay, the first topic will be the alcoholic hepatitis. Right. Now, if you take this alcoholic hepatitis, okay, already I have said you, this particular PDF is available on my Telegram channel, and my Telegram channel name is Medicine Made Easy by Dr. Rajesh Gubba. So you can join onto my Telegram channel and you can download this PDF, right? Now, you don't require to write anything I'm telling you, you just listen whatever I'm teaching, okay? Now, so if you see the spectrum in case of the alcoholic hepatitis, there are three important things in the spectrum. First, initially, the patient will develop the fatty liver. And if he continues to drink, then he will develop the alcoholic hepatitis. And further he continues to drink, then he goes into a state of the alcoholic cirrhosis. There's one stock question always been asked, what is the cause of sudden cardiac death if the individual is consuming a binge alcohol? Consuming of binge alcohol, the cause of sudden cardiac death will be the development of atrial fibrillation. And that is what is being termed by the Western people as the holiday heart syndrome. And next important thing you need to know in the alcoholic hepatitis is what will be the pathological features. So in the pathological features, I have given you the entire list of the pathological features, but what is the important MCQ in this pathological features is what you need to know. The MCQ in this pathological feature is the presence of the inclusion bodies and the name of the inclusion bodies, that is the Mallory-Denk bodies. Please remember, this will be a question which will be integrating your medicine and as well as pathology, right? But the examiner is like, if he is very much keen enough, he wanted to trouble you a lot, then in such case, what is that he may ask you is, Next, so if the examiner wants to trouble you about the Mallory-Denk bodies, what is the next level of the question is, like he will be asking you, what are the other conditions where you have the presence of the Mallory-Denk bodies? So please remember, right, please remember, it is observed in alcoholic hepatitis. That is what we are discussing. The other conditions will be in case of the obesity, right? That is the non-alcoholic steatohepatitis. Then the individuals with high copper intake, that is Indian childhood cirrhosis, and as well as Wilson's and primary biliary cirrhosis. So these are the other conditions where you have the presence of the Mallory-Denk bodies. And the next level of the question that they will be asking you in the alcoholic hepatitis is, what are the risk factors for the development of this alcoholic hepatitis? I'll tell you what is the question. The question is your HCV. Okay, so the HCV viral infection, this is a very important risk factor for the development of the alcoholic hepatitis. Now, what will be the clinical features? Very simple to make out, right? Hepatitis, right? So there will be inflammation of the liver parenchyma. So thereby, this individual will be having right upper quadrant discomfort, right upper quadrant discomfort. And as the alcoholic hepatitis progresses, the individual will go into a state of alcoholic cirrhosis. That is when the individual will have the palmar erythema, spider nevi, Dupuytren's contracture, and the features of the portal hypertension will be there, right? Then, how will you diagnose this alcoholic hepatitis? See, one important, what is the first line investigation is the question that will be asked for you. What is the first line investigation in case of the alcoholic hepatitis? So that will be, that means first line imaging. I mean to say first line imaging. The first line imaging will be the ultrasound abdomen. What is that you will notice in the ultrasound abdomen? Within the ultrasound abdomen, you will notice that there is increased liver span. There is increased liver span. Then, what is a confirmatory test for your alcoholic hepatitis? That is another question. That is another question. And that can be the liver biopsy. What will be there in the liver biopsy? That is your Mallory-Denk bodies. So what are the other features that you will have in liver biopsy is there will be ballooning of the hepatocytes. There will be macrovesicular fat deposition, neutrophilic infiltration, spotty necrosis, and Mallory-Denk bodies. That is what you will observe on the liver biopsy, right? And next important is, because liver is the site where you have the synthesis of the coagulation factors, once liver is damaged, like what will happen? The coagulation factors are not synthesized. Thereby, what will happen to the PT and INR? There will be elevated PT and as well as the INR. Okay. Now, what is another important question that can be asked in alcoholic hepatitis? I'll tell you. That is about the enzymes. That is about the enzymes. So, what are these particular enzymes that are being elevated? So, the enzymes that are being elevated is your SGOT and as well as the SGPT. What is the question here, sir? SGOT, SGPT तो like हर hepatitis में elevate हो जाएगा. But what is the important question here that can be asked here is, you have to know that the SGOT to SGPT ratio, this will be more than 1 in case of the alcoholic hepatitis. Whereas you take in case of the viral hepatitis, SGPT to SGOT ratio will be more than 1 in case of the viral hepatitis. So this is a very important question that will be asked in your exam. Now, the next important thing is, just now I was discussing about the MELD score, right? And now, what are the parameters in the MELD score is very commonly asked question. What is that parameters? Just now, as I have said, the parameters that will be there is bilirubin, INR, and as well as serum creatinine. But what is the importance of the MELD score? The importance of the MELD score is that this will decide when to start the treatment. Now, if suppose if the score of the individual is more than 21, that is when you need to start the treatment with steroids. Okay, the treatment that you need to give is steroids, but the score should be more than 21. Okay. Now, apart from this, another important scoring system is the Glasgow score. Right? The another important score is the Glasgow score. Now, what is this particular Glasgow score and what are the parameters in this Glasgow score is? Yeah, please make a note of it. Age, WBC count, blood urea nitrogen, bilirubin, and as well as prothrombin type. And what should be the score to start the treatment? If the score of the individual, right? If the score of the individual, if it is more than 9, that is the point when you need to start the steroids. Okay, that is about the Glasgow score. And we have one more important score for the alcoholic hepatitis, that is Madry's discriminant function score. That is Madry's discriminant function score. Now, what is the role of Madry's discriminant function score? Again, the same thing. This will also tell you about the severity of the alcoholic hepatitis. Now, according to your Madry's discriminant function score, when is that you should start the treatment? If the score of the individual is more than 32, that is the point when you need to give steroids. So, MELD score ke hisab se, according to MELD score should be more than 21 to start the steroids. According to Glasgow score, it should be more than 9 to start the steroids. According to Madry's discriminant function score, it should be more than 32 to start the steroids. Okay, right. Now, what is the treatment? Right, what is the treatment that you need to start with? So first and foremost, the alcohol de-addiction. So how is that you will do this alcohol de-addiction? The alcohol de-addiction, it is done with the help of two important molecules, that is naltrexone or acamprosate. But what is the drug of choice? In any form of hepatitis, what is that you need to give is the prednisolone. Any form of hepatitis, in the sense alcoholic hepatitis. So you need to give the prednisolone. If the patient is having some contraindications because of development of the Cushing syndrome, then you need to start this pentoxifylline. Then you need to start the pentoxifylline, right? So this was about your alcoholic hepatitis. So what is the take-home message for the alcoholic hepatitis? That is, your SGOT to SGPT ratio will be more than 1. The first line imaging investigation will be ultrasound abdomen. Investigation of choice will be biopsy, where you will have the presence of the Mallory-Denk bodies. And the scoring systems which will decide to start the treatment is, that is your MELD score, Glasgow score, and Madry's discriminant function score. And the drug of choice will be the steroids. So this is about your alcoholic hepatitis. Okay? Done. Once we are done with the alcoholic hepatitis, right. Now, the next topic for the discussion will be the cirrhosis and as well as its complications. Cirrhosis and its complications. Okay. Yeah, obviously, in case of the acute phase, we don't do the biopsy, right? But once the acute phase is over, that is when you need to do biopsy to confirm the alcoholic hepatitis. To confirm the alcoholic hepatitis. Okay. Right. Yes. Yeah. Anyone want to make an attempt of this question? Match the following clinical scenario in portal hypertension with their respective choice of treatment. So one scenario is non-bleeding esophageal varices, in which scenario you will do. Bleeding esophageal varices, what is that you will do? Recurrent bleeding with class A child pug, what is that you will do? Recurrent bleeding with class B and class C child pug, what is that you will do? Yes. Okay. So now here, the answer is, I'll directly tell you the answer. The answer is B. Now in patients with the non-bleeding esophageal varices, in patients with the non-bleeding esophageal varices, what is that you will give is, you give beta blockers, either propranolol or the nadolol has to be given, right? Whereas in case of the bleeding esophageal varices, in bleeding esophageal varices, right, you will be giving the drugs like either terlipressin or IV octreotide should be given. Either terlipressin or IV octreotide should be given. And those individuals who are having recurrent bleed with class A child pug, in them, the peritoneal venous shunt has to be done. But in those individuals with recurrent bleed with class B and class C child pug, what is that you have to do in that individual is, you have to do TIPS. Right? You have to do TIPS. Okay. So this is about how the questions can be framed. Actually, this is a question of one of the complications of the cirrhosis of liver, that is portal hypertension. Okay. So now, what is the first thing that we will be discussing now is, I said you, like the entire medicine, I have just made it in the form of tables. I'll summarize each and every topic in the form of tables, right? And those students who are joining new, so the PDF of this particular channel, this session is already available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can download it from there, right? Next. So now let us discuss, or let me quickly recap the topic of the alcoholic hepatitis, right? So first and foremost question, this cirrhosis, I'm sorry, now let me discuss in detail about the cirrhosis. First and foremost question, cirrhosis, is it reversible or not? Yes. Cirrhosis, is it reversible or not? So what you have to remember is cirrhosis, it is reversible, right? Cirrhosis, it is reversible in early stages, right? Cirrhosis is reversible in early stages. Now, in case of what is that early stages? Like you have the formation of the bridging fibrous septa, formation of the parenchymatous nodules, and there is disruption of the liver architecture. Now, when will this cirrhosis be reversible? Now, if at all, if you are able to stop that insult at the level of bridging fibrous septa, that is when the cirrhosis can be reversible. Then what are the various causes of the cirrhosis? Okay, like you have multiple causes. Alcoholic liver disease, viral hepatitis like hepatitis B, C, D, autoimmune hepatitis, non-alcoholic steatohepatitis. Okay, I have given you this entire list. You can go through this. But out of all this, sir, question kya pooch sakta hai, right? If you take this nodules, you have micronodular cirrhosis and macronodular cirrhosis. Micronodular cirrhosis means where the size of the nodule is less than 3 mm. Macronodular cirrhosis means where the size of the nodule is more than 3 mm. Now, the question that will be asked is, what is the most common cause of the micronodular cirrhosis? The most common cause of the micronodular cirrhosis will be the alcohol, whereas the most common cause of the macronodular cirrhosis, that will be viral hepatitis. That will be viral hepatitis. Okay, that's a very important thing that you need to know in the entire etiology. What are the complications of cirrhosis of liver and what are the clinical manifestations? So, if you take the complications, like in patients with cirrhosis of liver, there is hypoalbuminemia and liver is completely congested. And because of which the portal hypertension that will be causing ascites. The other complications are hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome, spontaneous bacterial peritonitis. These are all the complications. And what are the clinical features like spider nevi, palmar erythema, Dupuytren's contracture, clubbing, parotid enlargement? Okay, a big list of the clinical manifestations are there. But what are the questions that I'll tell you? The question that can be asked is about this spider nevi. What is the cause for the development of spider nevi? Right? It is mainly because of increase in the estrogen level in case of cirrhosis of liver. That will be the reason for the development of the spider nevi. And increase in the estrogen level is also the reason for the development of the gynecomastia as well. Right? Next. And caput medusae. Why is this caput medusae? That is another important question that can be asked. So caput medusae, it occurs mainly because of the portal hypertension, and the portal vein, it has the anastomosis with the umbilical veins. Once the portal venous pressure is increased, the umbilical venous pressure is also increased, and that can result in the caput medusae. Okay, so these are the complications. Now, what are the scoring systems in case of the cirrhosis of liver? Almost the same, whatever we have discussed in the alcoholic hepatitis just now. That is your MELD score and as well as Child-Pugh score. Now, sir, what is important in this particular scores? You need to remember the parameters. See, even in your sleep also, you should not forget the parameters of MELD score, Child-Pugh score, and parameters of the Madri's discriminant function score, parameters of PELD score. You should never forget. That is one definitely asked question. So in MELD score, the parameters are bilirubin, INR, creatinine. Whereas in Child-Pugh score, the parameters are, right, in Child-Pugh score, the parameters are like the bilirubin, INR, the albumin, ascites, and as well as the asterixis. That is in case of the Child-Pugh score. And what is the purpose of doing this SAG? That is serum albumin minus the ascitic fluid albumin. Okay, that is what is SAG. So this will tell us whether the portal hypertension is present or not. If suppose, if the SAG value of the individual is more than 1.1, this tells you that there is portal hypertension. Now, what are the diagnostic tests? The diagnostic tests that you'll be doing is the liver biopsy. So liver biopsy is the one which will confirm the diagnosis. But always, what is the problem when you are doing liver biopsy in patients with cirrhosis of liver? See, there is like abnormal coagulometry. The PTINR is deranged in these patients. There is excessive chance of bleeding tendencies in these patients with cirrhosis of liver, right? Now, you cannot do liver biopsy. So in such case, what is a non-invasive investigation? The non-invasive investigation will be transient elastography. Transient elastography. That will tell you about the liver architecture. Now, coming to the treatment that you will be giving in liver cirrhosis. So basically, what is the problem in liver cirrhosis? There is ascites, there is pedal edema, there is fluid overload. So for that reason, you need to give a salt-restricted diet, and you should give diuretics. What are the diuretics that you will be giving? That is mainly you need to give the furosemide and as well as the spironolactone. And if the ascites is like massive ascites, then in such case, you need to do the abdominal paracentesis, or in case of the recurrent ascites, right? You are doing paracentesis, but again, there is accumulation of the fluid in the peritoneal cavity. If there is recurrent ascites, then you need to do a transjugular or transjugular intrahepatic portosystemic shunt. Okay. Now, coming to the management of the varices. So in the management of the varices, you need to decide whether these particular varices are non-bleeding esophageal varices or bleeding esophageal varices. Agar non-bleeding esophageal varices are there, then you need to give beta blockers, and followed by that you need to do endoscopic variceal ligation. If it is bleeding esophageal varices, then what is that you need to do is you need to stabilize the patient first. IV fluids you should give, blood transfusion you should give, then you should give this terlipressin or octreotide, and followed by that you need to do this particular sclerotherapy. Followed by that you need to do sclerotherapy. So this will be the management of the varices. Now, the another complication that we were discussing was the hepatic encephalopathy. What is the drug of choice in case of the hepatic encephalopathy? That is lactulose. What this lactulose will do? This lactulose, it will convert ammonia to ammonium, and ammonium is excreted out. That is what is the mechanism of action of this lactulose. And okay, next important is there is development of spontaneous bacterial peritonitis. Now, what is the most common organism that will be causing spontaneous bacterial peritonitis? That will be the Escherichia coli. That will be Escherichia coli. What is the drug of choice that will be killing your Escherichia coli? That will be intravenous cefotaxime. That is considered as the drug of choice. Now, you should decide in a patient with cirrhosis of liver, when is that you should do an orthoptic liver transplantation. This is a very, very important multiple choice, guys, right? Very, very important question. If the MELD score of the individual is more than 17, that is when you need to do the orthoptic liver transplantation. That is when you need to do orthoptic liver transplantation. Done? Right. So that was about the cirrhosis of liver. Okay. Right. Now, yeah. Sir, how does cirrhosis cause Dupuytren's contracture? See, why there is Dupuytren's contracture in patients with cirrhosis of liver is, in patients with cirrhosis, there is excessive fibrous tissue accumulation within the palmar aponeurosis. And because of the fibrous tissue accumulation within the palmar aponeurosis, there will be development of the Dupuytren's contracture, right? Yeah, the beta blocker that we need to give is propranolol, right? Rather than carvedilol. In patients with the non-bleeding esophageal varices with portal hypertension, we give propranolol or nadolol. Where do we give carvedilol? Carvedilol, we give it in the congestive heart failure. Congestive heart failure, okay? Yes, for spontaneous bacterial peritonitis, we give the prophylactic antibiotic, and that prophylactic antibiotic is quinolones. We give either norfloxacin or we give ciprofloxacin as the prophylaxis. Okay, right. Now, chalo, next question. To the complications. A patient with chronic liver disease, ascites, and no bleeding varices presented with the hematemesis and as well as melena. What is the next step in the management? Give injection vitamin K, give injection tranexamic acid, fresh frozen plasma transfusion, platelet transfusion. Chalo, what is that you want to do, guys, for this patient? Very good. So, in this individual, you need to give fresh frozen plasma. Why is that you are giving fresh frozen plasma? See, the patient is having a chronic liver disease. So when the patient is having a chronic liver disease, does this liver can synthesize the coagulation factors? No. So whenever you give this vitamin K is required for synthesis of factor number 2, 7, 9, 10 by the liver. But here the liver itself is damaged. So your vitamin K, is it useful? No. So vitamin K is of no use. tranexamic acid will stop only the bleeding, but it will not treat the underlying cause. So no role of no use of tranexamic acid here. Platelet transfusion should be given when the bleeding is mainly because of thrombocytopenia. But in patients with chronic liver disease, what could be the reason for bleeding? Because of defective coagulation factors. And this fresh frozen plasma contains the coagulation factors. That is the reason why you need to give FFP. Okay? Chalo. Then what is that we will discuss in detail now. So I'll be discussing in detail about the complications of the cirrhosis. Right? So the first important complication is what? That is portal hypertension. Sir, portal hypertension to humko pata hai, like what is the question that will be asked for us? I'll tell you two questions that are sure short questions, if at all, if they want to ask you the question on portal hypertension. One important is splenomegaly. Right? What is the earliest finding that you will have in patients with portal hypertension? That will be splenomegaly. That will be the first thing. Second important question, what they can ask, if at all, if they want to ask you on the portal hypertension, is what is the criteria or what is the definition or what is the cutoff pressure to call it as portal hypertension? That is when the portal vein pressure gradient, if it is more than 12 millimeters of the mercury, right? So if the portal venous pressure, if it is more than 12 millimeters of mercury, portal vein pressure gradient, that is mainly what I mean to say is hepatovenous pressure gradient. If it is more than 12 millimeters of mercury, then it is considered as the portal hypertension, right? And the next important complication is definitely ascites. Already ascites के बारे में हम already discuss कर चुका है. Okay. Now hepatic encephalopathy. Now in hepatic encephalopathy, I'll be discussing that in detail as well. What is the question, if at all, if they want to ask you is, what is the toxin that is elevated or what is this toxic substance which is elevated for the development of the hepatic encephalopathy? That will be your ammonia. Actually, ammonia has to be detoxified by the liver, but liver is damaged here, so ammonia cannot be detoxified, right? And what will be the earliest manifestation in the hepatic encephalopathy? There will be reversal of the sleep rhythm. And these individuals will be in a state of confusion. There can be asterixis and the individual can go into a state of coma as well. Then how is that you will manage this hepatic encephalopathy? Just now, as I have said you need to give lactulose. And what is the purpose of giving this rifaximin and neomycin? Rifaximin is given mainly to kill the gut bacteria because I don't want the excess ammonia to be produced. So how can I achieve this? By giving rifaximin. Rifaximin will kill the gut bacteria. So excessive synthesis of ammonia will not be there, right? And next important abnormality will be coagulopathy, right? What is this coagulopathy due to? That is mainly because of defective coagulation factor synthesis by the cirrhosis liver. Then what is that you should give as a treatment? The preferable treatment is fresh frozen plasma rather than vitamin K. So how can you tell that the individual has developed coagulopathy? That is by doing the INR. So INR will be elevated in these patients, right? And one more important complication is spontaneous bacterial peritonitis. So already I have said you two questions. Most common organism, Escherichia coli. And drug of choice, cefotaxime. If at all, if they want to ask you another question on spontaneous bacterial peritonitis, what is that they will ask you? They will ask you about the diagnostic criteria for spontaneous bacterial peritonitis. Mainly, there should be, whenever you are doing the ascitic fluid analysis, in the ascitic fluid analysis, the polymorphonuclear leukocytes should be more than 250 polymorphonuclear leukocytes per cubic millimeter. That is what you will observe in case of spontaneous bacterial peritonitis. Okay? Next. Coming to the variceal bleeding. Already I have discussed about the variceal bleeding also. So what will be the presentation in this individual? The presentation in this individual will be in the form of hematemesis, melena, and they may also go into a shock. And what will be, okay, there are three questions that I'll tell you. First line treatment in variceal bleeding coming with shock. First line treatment will be IV fluids, then followed by the blood transfusion, right? Next, what is the drug of choice in case of bleeding esophageal varices? The answer will be terlipressin, right? Then what is the treatment of choice in patients with a variceal bleeding? You should do esophageal variceal ligation. You should do esophageal variceal ligation. Now, one more question is, if there is recurrent, right? If there is recurrent variceal bleeding, then what is the treatment of choice? The treatment that you need to do is TIPS, that is transjugular intrahepatic portosystemic shunt. That is what is you need to do in case of recurrent esophageal variceal bleeding. Done? Okay. Next important complication is what? The hepatorenal syndrome. Now, in hepatorenal syndrome, please remember, it is acute kidney injury that you develop in case of cirrhosis of liver. And what could be the reason for this? That is due to renal hypoperfusion. And actually, you have two types of the hepatorenal syndrome, type 1 and as well as type 2. But which is that which has worst prognosis? Type 1 wala hepatorenal syndrome has worst prognosis. Then, how do you treat these patients with the hepatorenal syndrome? You need to give the drug of choice in type 1 hepatorenal syndrome will be either terlipressin or octreotide. The other alternative will be midodrine, which is the alpha-1 agonist. Okay, so this is what is your hepatorenal syndrome. Next important complication is what? That is hepatopulmonary syndrome. Hepatopulmonary syndrome. Now, in patients with hepatopulmonary syndrome, what is that you need to remember is these patients will have orthodeoxia. These patients will have orthodeoxia. What is orthodeoxia? Orthodeoxia is that whenever the individual sits, they will have dyspnea, and whenever the individual lies down in supine position, the dyspnea will disappear. So orthodeoxia is a very important feature in hepatopulmonary syndrome, which is a complication in cirrhosis of liver, right? And what is the differential diagnosis for the orthodeoxia? Differential diagnosis for the orthodeoxia. Yes, anyone want to answer what is the differential diagnosis for orthodeoxia? Yeah, see, overall, what is the most common cause for cirrhosis of liver? Overall, the most common cause for the cirrhosis of liver, it is the alcohol and viral hepatitis. These two are the overall most common causes, right? Yeah, so the differential diagnosis for orthodeoxia will be atrial myxoma. Right, so this will be atrial myxoma, okay, not ASD. It is atrial myxoma. All right, so this is about, and what is the treatment that you will be giving in case of hepatopulmonary syndrome? The treatment that you will be giving is the oxygen supplementation, and ultimately these patients will be requiring the liver transplantation. Ultimately these patients will be requiring the liver transplantation. Okay, right. Now, apart from this, what are few more complications that can be seen in patients with the cirrhosis of liver? Few more complications that can be seen is the osteoporosis. Why there is osteoporosis in patients with cirrhosis of liver? That because liver is the site where you have the formation of the precursor of the vitamin D, that is 25-hydroxy cholecalciferol. 25-hydroxycholecalciferol, it is formed in the liver. When liver is damaged, your vitamin D is not formed, and that will result in the development of the osteoporosis. Okay. Next, malnutrition. Why malnutrition? Because liver is the site where you have metabolism of your carbohydrates, proteins, and lipids. And if liver is damaged, your gluconeogenesis does not occur, protein and lipid metabolism does not occur, and that will result in the development of the malnutrition. Now, what is this? The hepatic hydrothorax. So this hepatic hydrothorax is nothing but hepatic hydrothorax is nothing but the development of the pleural effusion. The patients who are having the ascites, the fluid can enter into the pleural cavity. That is what is called as the hepatic hydrothorax. And patients who are having hepatic hydrothorax, what is that they will develop? They will develop dyspnea, and that is due to pleural effusion. So how do you treat these patients? You need to give diuretics and salt restriction. Because there is pleural effusion, what is that you need to do is you need to do a pluricentesis, which is also called as thoracocentesis, Now, the another important complication is abdominal compartment syndrome. When will you develop this abdominal compartment syndrome is when the individual is in a state of tense ascites. When the individual is in a state of tense ascites, they will develop abdominal compartment syndrome. So in abdominal compartment syndrome, intra-abdominal pressure will be more than 25 millimeters of mercury. The intra-abdominal pressure will be more than 25 millimeters of mercury. And immediately you need to do the abdominal paracentesis. If you don't do abdominal paracentesis, the individual can go into a state of respiratory distress and respiratory failure. Right now, after doing abdominal paracentesis, if there is recurrent ascites, then what is that you need to plan for? You need to plan for the transjugular intrahepatic portosystemic shunt. Okay, so that was the story related to the complications in case of cirrhosis of liver. Okay, so I will show you one question regarding the complications. Yeah, please answer this. What is the maximum dose of the albumin that can be used to treat the patients with hepatorenal syndrome? So what actually is the reason why you need to give albumin? Because albumin is the one which will cause the volume expansion and it can increase the renal perfusion. Chalo. Now we are done with the complications of the cirrhosis of liver and the cirrhosis. We will move on to the next topic, that is viral hepatitis. Next topic, that is viral hepatitis. And to those students who are joining as new, this PDF of this session has already been shared on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. So you can just download the PDF from that particular Telegram channel. Okay. What is that will be asked very commonly on the viral hepatitis? Okay. So serology is very, very important. Chalo, anyways, what I will do, I will just do a detailed discussion of the viral hepatitis. First and foremost, nuclear material. What is the nuclear material in viral hepatitis? The nuclear material in viral hepatitis, it is the DNA virus, right? It is the DNA virus. Okay. Now, following that, you need to know, okay, the nuclear material is the DNA virus. Right. Following that, you need to know one important terminology, that is called Dane particle. What is Dane particle? If you are able to visualize the complete virion that of hepatitis B under the microscopy, that is what is called Dane particle. Right? Now, this is the question. This is a question here. What is the question here? What is the serological marker that appears first in case of viral hepatitis? That is HBsAg. So अगर वायरल हेपेटाइटिस के बारे में अगर क्वेश्चंस पूछना है तो the question will be on the serology. The question will be on serology. Okay. Now, coming to the core antigen. Please remember, the HBC core antigen will never appear in the blood. Why? Because it will remain within the hepatocyte nuclei itself. Another important serological marker is envelope antigen. Envelope antigen, it will tell you about the replication and as well as the infectivity. Next important marker is the HBV DNA. HBV DNA, this will tell you about the quantitative assessment. Right, so this will tell you about the quantitative assessment of the hepatitis B. Done. Next. So this is like the serology related to structure. I did not still discuss the antibodies. Coming to the transmission. So if you see the transmission can occur by percutaneous, parenteral, and as well as the vertical transmission, right? Parenteral, percutaneous, then sexual transmission is another important transmission. There is one question asked, this was a PYQ, among the various viruses, which particular virus has the greater chances of spread via percutaneous injury or by needle prick? The options are the hepatitis B, the hepatitis C, then HIV. Among these three viruses, which particular virus is being spread maximally by the needle prick? Hepatitis C, the chance of transmission is 3%. HIV, the chance of transmission is 0.3% by the needle prick. Okay, so please remember the percentages also. Done. Now, after having discussed about the antigens, then we will also discuss about the antibodies. So first serological marker is what? Surface antigen. Now to that particular surface antigen, you have the formation of the protective antibody, that is anti-HBsAg, right? And I said you that core antigen will never appear in the blood because that will remain within the hepatocytes. Okay. Then what is the antibody to the core antigen? The antibody to the core antigen is the anti-HBsAg, right? And this particular anti-HBsAg, what will be the antibodies? That is the IgM and IgG. IgM anti-HBc in case of acute viral hepatitis. IgG anti-HBc present in the chronic viral hepatitis. Envelope antigen already I have discussed. That is the one which is seen in case of the high infectivity. Now, next to the serology, if at all, if they want to ask you one more question related to the enzymes, already I have said this in the alcoholic hepatitis also, but let me repeat once again. So, SGPT to that of the SGOT, will be more than 1 in case of viral hepatitis. Whereas in case of alcoholic hepatitis, what is that you will have? You will have exactly reverse. That is SGOT to SGPT will be more than 1 in alcoholic hepatitis. Done? Next. Coming to the diagnosis, I have already said you that is by your viral load and serology and all. Okay, what is the question here is, the question is on the ultrasound abdomen. Ultrasound abdomen in acute viral hepatitis, what is the appearance? That is the starry sky appearance. And this starry sky appearance, I hope like you know all these questions, right? Lymph node biopsy showing starry sky appearance. Where is that you will have lymph node biopsy, starry sky appearance. Very good. Burkitt's lymphoma, right? Then CT brain starry sky appearance. Where is that you will have? Very good. That is neurocysticercosis. Done. Then renal biopsy showing the starry sky appearance. Where is that you will have? Very good. That is in case of the post-streptococcal glomerulonephritis, right? So these are the 4 questions on the starry sky appearance. Okay. Now coming to the treatment of the acute hepatitis B. Please remember, in acute hepatitis B, you don't give antiviral drugs because 90% of them, they'll have spontaneous recovery and only supportive care has to be given. Symptomatic management has to be done in case of the acute viral hepatitis. Okay. Then followed by that, the chronic hepatitis B. Chronic hepatitis B, you need to definitely give antiviral drugs. Question क्या पूछ सकता है in the treatment of chronic hepatitis? Please and please remember this criteria in order to start the antiviral drugs. So envelope antigen should be reactive. HBV DNA viral load should be more than 2 into 10 to the power of 4 international units per ml. And the SGPT should be elevated. That is when you start the antiviral drugs. And which antiviral drug you will start? That is tenofovir. And for how many days you will give? 300 milligrams per day, 48 weeks you will give. And whenever you're giving tenofovir, what is it you need to monitor? You need to monitor the kidney function. Okay, so this is about the treatment of the hepatitis. And what is the complication? Chalo, your viral hepatitis is the one which will be causing cirrhosis and as well as the hepatocellular carcinoma. Okay, now do you have vaccines available for the hepatitis B? Yes, vaccine is available for hepatitis B. Vaccine is available for the hepatitis A and as well as the hepatitis E as well. But the question to be asked is, for which virus the vaccine is not available? For hepatitis C, vaccine is not available, right? This is about the hepatitis B. This is about the hepatitis B. Okay, now we'll move on to the next discussion. Right, so far so good, everything is fine. How is the session going on? Right, just I think 40 minutes over. As of now, I think everything is comfortable, no problem. Chalo, theek hai. Now we'll move on to the next Hep C, Hep B and the fulminant hepatitis. Chalo, you see this question and please answer. I'll be just back in 1 minute, guys, only one. Chalo. So what is the correct answer here? The correct answer here is C, because the hepatitis B, it is a transfusion related hepatitis, right? And the hepatitis E, if you see, it is the fulminant hepatic failure in pregnancy. Then you take the hepatitis C, this is the one which commonly requires the orthoptic liver transplantation. And hepatitis D, it always requires the co-infection with the hepatitis B. Chalo? Chalo. Now we'll start with the discussion of this individual viruses. Now, regarding this, the hepatitis C, what is the question that can be asked regarding the nuclear material? So regarding the nuclear material, for hepatitis B, I said you it is DNA virus, but for hepatitis C, please remember it is a single stranded, the RNA virus, right? And if at all, if the question has to be asked on the hepatitis C, what is very important, as already I have said you about the vaccine. Vaccine is not available. And what are the antibodies in case of the hepatitis C? The antibodies in hepatitis C is the anti-LKM antibodies. The antibodies are the anti-LKM antibodies. And among all the viral hepatitis, please remember the viral hepatitis which is associated with the extrahepatic manifestation, that will be your hepatitis C. What will be that extrahepatic manifestation? I have given you the list there, right? One thing please remember, they have given you 4 options of hepatitis A, B, C, D, but some Extrahepatic manifestations are there in the given clinical scenario. Blindly close your eyes and mark your hepatitis C, right? So what will be that extrahepatic manifestation? Arthralgia, myalgia, paresthesias, lichen planus, aplastic anemia, diabetes mellitus. So these are all the extrahepatic manifestations. Okay. Then what is the antiviral drug? Actually, what is that we were giving in case of hepatitis B, we were giving tenofovir. But here we give actually according to the genotype. But the commonly used the antiviral drugs are sofosbuvir and velpatasvir. That should be given for 12 weeks. And the other important antiviral drug for the hepatitis C will be glicapravir plus pibrentasvir. That will be the antiviral drugs for the hepatitis C, right? And is there any post-exposure prophylaxis for hepatitis C? No. For hepatitis B, you have the post-exposure prophylaxis. Then how is that you will confirm the hepatitis C needle prick injury? So hepatitis C needle prick injury, it is confirmed by the HCV RNA PCR for confirmation. That is for the hepatitis C treatment. Now, we were discussing about the hepatitis D. So hepatitis D, I said you it is always an incomplete virus and it requires always a company of the hepatitis B, right? So this requires the hepatitis B co-infection. And how is it being transmitted? That is parental route. So what is it required for? The life of it, that is HBV. So HBV should always be present. Now, whenever there is HBV co-infection, there is increased chance of the fulminant liver failure. There is increased chance of fulminant liver failure. Now, if at all, if you want to eliminate the hepatitis D, what is that you need to do is you vaccinate. You give 100% hepatitis B vaccination that will eliminate the hepatitis D. Right? So that was the story of the hepatitis D, which is called Delta virus. One more important is fulminant hepatic failure. What is the criteria to call it as fulminant hepatic failure? The criteria to call fulminant hepatic failure is if there is rapid liver destruction within 8 weeks, that is called the fulminant hepatic failure. What are the causes for fulminant hepatic failure? Okay, you have many things. You have toxins, you have the viral infections. So, and among the viral infections, the very important viral infection is the hepatitis B and hepatitis D co-infection and hepatitis E in pregnancy. Hepatitis E in pregnancy, right? And the next important is the workup for the fulminant hepatic failure. So the workup, okay, the usual workup for any liver pathology, SGOT, SGPT, coagulogram, USG abdomen, and then the MELD score. What is the treatment? See, the problem in patients with the fulminant hepatic failure is they go into a state of the hepatic encephalopathy. So what is the drug of choice for hepatic encephalopathy? You need to give lactulose. And I already said you why you should give this rifaximin and as well as neomycin. So you should give rifaximin and as well as neomycin mainly to prevent the bacterial growth. Then you should also give the drugs which will convert the ammonia to glutamine, and the glutamine is excreted by the kidneys. So what is that particular drug that you will give? That is LOLA. What is LOLA? That is L-ornithine L-aspartate, right? L-ornithine L-aspartate. That converts the ammonia to glutamine, and that glutamine is excreted by the kidneys, okay? And in refractory cases of the hepatic encephalopathy, what is that you will do? You have a form of dialysis that is called MARS. What do you mean by this word MARS? That is molecular absorbent reabsorbent circulating system. That is what is called MARS. And already I have said you when to do the orthoptic liver transplantation. Orthoptic liver transplantation has to be done mainly when the MELD score is more than 17. That is when you need to do the orthoptic liver transplantation. Okay. So this is about the story related to the fulminant hepatic failure, right? Next topic is the autoimmune hepatitis. Next topic is autoimmune hepatitis. And in autoimmune hepatitis, what are the antibodies? The anti-LKM antibodies. Okay, chalo, match the following. Right. So, yes, very good, Anash. The answer is C. Right, the answer is C. So, anti-LKM1 that is associated with the hepatitis C. Anti-LKM2 that is observed in drug-induced hepatitis. Anti-LKM3 that is present in the HDV infection. That is present in HDV infection. Okay. So this autoimmune hepatitis, if you see, there are three types. What are the three types of these autoimmune hepatitis? These are the three types of autoimmune hepatitis. That is autoimmune hepatitis 1, 2, and as well as 3. So this autoimmune hepatitis 1, the antibodies are anti-nuclear antibody, then anti-smooth muscle antibody, and soluble liver antigen. Whereas autoimmune hepatitis type 2, the antibodies that you will have is mainly anti-LKM1, 2, and 3. 1 in hepatitis C, 2 in drug-induced hepatitis, 3 in hepatitis D. And autoimmune hepatitis type 3, the antibody is anti-soluble liver antigen. That is your autoimmune hepatitis 3. Right now, what are the questions that can be asked for you on the autoimmune hepatitis? What is another name for autoimmune hepatitis? It is called as leukoid hepatitis or plasma cell hepatitis. Leukoid or plasma cell hepatitis. What could be the reason? Because there is association of the SLE. That is the reason why it is called as the leukoid hepatitis. And in the pathophysiology, which particular cells play an important role in the attack of the liver antigens? That is the T8 mediated attack. T8 mediated attack. What are the etiologies? Already just now I have said you about the types of autoimmune hepatitis 1, 2, 3, and depending upon that you have the various etiologies. And always remember, these autoimmune hepatitis, it is associated with other autoimmune conditions. What are the other autoimmune conditions? Like hypothyroidism, Hashimoto's thyroiditis, malabsorption syndromes like the celiac sprue and ulcerative colitis, and renal pathology, that is membranoproliferative glomerulonephritis. Right? And regarding this anti-LKM1, 2, 3, already I have discussed. But please remember, in case of autoimmune hepatitis, we have a form of ANCA called ex-ANCA. Actually, ANCA, like how many types you have? P-ANCA, C-ANCA. P-ANCA is present in microscopic polyangiitis and Church-Strauss syndrome, and C-ANCA is present in case of Wegener's granulomatosis. But in autoimmune hepatitis, what is that you'll have is the ex-ANCA is being present. Ex-ANCA is being present in case of the autoimmune hepatitis, right? Now, so next coming to the clinical features. Clinical features, what it will be there? It will be like same to that of any liver pathology, right? Initially, they will be asymptomatic. Later, they will be developing jaundice. But here, the additional features that they can have is associated autoimmune conditions. Like, for example, autoimmune hepatitis, if it is associated with Sjogren's, they can have Sicca syndrome, right? And if this particular autoimmune hepatitis, if it is associated with sarcoidosis, they can have this erythema nodosum. And all other features of the liver problem, like cirrhosis, ascites, varicose, everything is same, right? And is there any risk of cirrhosis in these individuals? Definitely. Which particular patients of autoimmune hepatitis will go into cirrhosis? That is observed in elderly patients. That is observed in the elderly patients, right? Now, in the workup of autoimmune hepatitis, you need to work up for the liver function, and you need to work up for the underlying etiology like viral hepatitis, HIV, HBV, and HCV. Obviously, your PTINR will be raised because liver is damaged. RF factor can be positive because it is associated with many other autoimmune conditions. And always this autoimmune hepatitis, it is the diagnosis of exclusion. That means first you need to exclude viral etiology. You need to exclude the drugs, alcohol, genetic causes. After excluding all others, then you need to consider it as autoimmune hepatitis. Now, in any autoimmune hepatitis, basically what is this? It's an autoimmune condition, right? So what is that you'll give? Steroids dena hai. So you should give the steroids. And what is that particular steroid? That is prednisolone. Okay. Now, but this you cannot give for long term because the individual may develop Cushing's syndrome. So what is that you need to give in order to prevent the development of the Cushing's as a maintenance? As a maintenance, you need to give the azathioprine. In the late stages, what is that you will do? In the late stages, you need to do orthoptic liver transplantation. In late stages, you need to do orthoptic liver transplantation. Okay. Now, is there any recurrence after doing orthoptic liver transplantation? Yes. Autoimmune hepatitis may recur in the transplanted liver. Okay. So this is about the autoimmune hepatitis. This is about autoimmune hepatitis. So what is very, very important in autoimmune hepatitis that you need to remember? This table is very important, right? Which antibodies are present in autoimmune hepatitis type 1, type 2, and as well as type 3. And where is that you will have anti-LKM1, anti-LKM2, anti-LKM3, right? Now, we'll move on to the next topic in the liver, that is the Budd-Chiari syndrome. And those students who are joining now and completely new onto this particular channel, let me tell you, the PDF of this particular topic is available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba, right? And if you are liking my session, right, you can follow me on my Instagram handle, that is Rajesh Gubba, right? Why is that you need to follow me? Because I'll be posting the clinical material on my Instagram handle every day. So you can just follow and you can just go through the clinical material that I'll be posting every day on my Instagram handle. Okay? Now, coming to the clinical scenario, like a female presents with the severe abdominal pain. Examination shows jaundice, tender hepatomegaly, and mild ascites. What is the most likely diagnosis in this patient? Right. So it is the Budd-Chiari syndrome. It is your Budd-Chiari syndrome. So Budd-Chiari syndrome, the classical presentation will be the ascites, jaundice, and the abdominal pain. Right. These three are very important features in case of the Budd-Chiari syndrome. And basically, what is the problem in the Budd-Chiari syndrome? The problem in the Budd-Chiari syndrome is that there is obstruction in the hepatic veins, and this particular obstruction is caused by the thrombus. This obstruction is caused by thrombus, and because of that, the blood from the portal vein is not entering into the hepatic veins. So thereby what will happen? These patients will develop portal hypertension, and it's a post-hepatic cause for the portal hypertension. And because the venous blood is not able to enter into the hepatic vein, the liver get congested and there will be necrosis of the liver. And the type of the necrosis will be centrilobular necrosis. Now, what could be the etiologies that would be causing this Budd-Chiari syndrome? Basically, Budd-Chiari syndrome, what is the problem? Thrombus formation. Where all you can have thrombus formation? We have some hematological conditions like polycythemia vera and paroxysmal nocturnal hemoglobinuria. Then hypercoagulable states like protein C, protein S deficiency. Then we have some drugs, oral contraceptive pills that too rich in estrogen can cause hypercoagulability. Tumors like hepatocellular carcinoma and renal cell carcinoma can cause the hypercoagulability, right? And then we have connective tissue disorders like APLA, where there will be hypercoagulability, where there can be formation of the thrombus within the hepatic veins. Okay, so this is about the etiology that will be causing the Budd-Chiari syndrome. Clinical features, just now I was telling you, this is a triad. What is a triad? Right upper quadrant pain, ascites, and hepatomegaly. These three are the triad in Budd-Chiari. Why there is jaundice in this patient? Because there is centrilobular necrosis. That is the reason why these patients have jaundice. And other features of the liver pathology, hepatorenal syndrome, pedal edema, all other features will be there. Now, the question is, how will you diagnose? The question is, how will you diagnose? The investigation of choice will be hepatic venography. Hepatic venography is the one which will show you that there is presence of the thrombus. And this patient has ascites. When you do an ascitic fluid tap and when you check the SAG value will be more than 1.1. And if SAG value is more than 1.1, that is suggestive of the portal hypertension. So then how do you treat these patients with the Budd-Chiari syndrome? The treatment of Budd-Chiari syndrome is, if it is acute form of Budd-Chiari syndrome, then you need to do the balloon angioplasty and anticoagulation therapy has to be given. But if it is the chronic form of the Budd-Chiari syndrome, then you need to do TIPS, that is transjugular intrahepatic portosystemic shunt has to be done. But if suppose if the patient is having ascites, okay, you need to give diuretics, that is spironolactone and all can be given. But because of this Budd-Chiari syndrome, the individual has gone into an end-stage liver disease. That is a point when you need to do orthoptic liver transplantation. That is a point when you need to do orthoptic liver transplantation. Chalo, this is about your Budd-Chiari syndrome, right? What is that you will remember in Budd-Chiari syndrome now? Thrombus in the hepatic vein, because of which portal hypertension, centrilobular necrosis. Okay, multiple etiologies are there. Clinical features, triad, right upper quadrant pain, ascites, and as well as hepatomegaly. Investigation of choice, hepatic venography. Acute cases, balloon angioplasty. Chronic cases, TIPS, transjugular intrahepatic portosystemic shunt. Done? Now, next important two topics, that is primary biliary cirrhosis and as well as primary sclerosing cholangitis, right? These are the two next topics. So, first let me discuss primary biliary cholangitis, then followed by the primary sclerosing cholangitis. Okay. Now, if you take this primary biliary cholangitis, let me tell you, it's an autoimmune condition and there is damage to the bile ducts. Which particular bile ducts are affected? That is mainly intrahepatic bile ducts are damaged, right? Small intrahepatic bile ducts are damaged. What is the HLA association? I don't know why in the recent times the examiners are becoming very much conscious on this HLA. In the recent exam also, there was a question on the HLA in the celiac disease, right? And please remember the HLA of the primary biliary cholangitis, that is HLA-DR-B1 and the HLA-DQ-B1. What will be the clinical manifestations? Liver is damaged, so metabolism does not occur, ATP synthesis does not occur. Thereby, these patients, they have fatigue. That is the earliest manifestation. And I have said you it is an autoimmune condition. So what should be the antibody? The antibody will be anti-mitochondrial antibody, right? And there are totally 4 stages in case of the primary biliary cholangitis. In stage 1, you have portal damage. And in stage 4, you have cirrhosis of liver. Then how do you work up? So if you see the workup in these patients, enzymes are elevated. SGOT, SGPT elevated. That will be there in any form of hepatitis. But what is a marker of the obstruction? The marker of the obstruction is the alkaline phosphatase levels are elevated. What is the investigation of choice? The investigation of choice will be the liver biopsy. Liver biopsy is the one which will give you the picture of the primary biliary cholangitis. What are the drugs that you should give in these individuals? Whenever you give this ursodeoxycholic acid, that will slow down the liver disease. But if the individual is intolerant to ursodeoxycholic acid, then you can give the obeticholic acid, right? And in these patients, the bile acids and as well as bile salts, they enter into systemic circulation and they are wasted out. So what is that particular drug which will cause the sequestration of the bile acids? That is the cholestyramine, right? Now, in refractory cases, what is that you need to know? What is the problem here? Antibodies, that is anti-mitochondrial antibodies. Now, these anti-mitochondrial antibodies have to be kicked out. What you should do or what you can do? Plasmapheresis. And the definitive treatment in these patients will be orthoptic liver transplantation is what you need to do in case of the end-stage liver disease as a definitive treatment. That is about primary biliary cholangitis, right? What is the problem? Small intrahepatic bile obstruction. HLA, very important. DRB1, 08, DQB1. Earliest manifestation, fatigue. Investigation of choice, liver biopsy. Important molecule to be given, ursodeoxycholic acid. Refractory cases, plasmapheresis. Definitive treatment, orthoptic liver transplantation. Done? Next, we'll move on to next topic, that is primary sclerosing cholangitis. Primary sclerosing cholangitis. In primary, what is the difference between these two is, in primary biliary cholangitis, it is only intrahepatic bile duct problem. Whereas in primary sclerosing cholangitis, it is both intra and as well as the extrahepatic bile duct problem. Okay. And these patients with the primary sclerosing cholangitis, they are at increased risk of cholangiocarcinoma. And please remember, this is a very important question, right? They are at increased risk of cholangiocarcinoma. What does the biopsy show? When you do a biopsy, you will have the onion skin fibrosis, right? The fibrous tissue is accumulated in the form of the whorls. And next important is the ERCP. Whenever you do ERCP, that is enteroretrograde cholangiopancreatography, ERCP will show you that there is beaded appearance. That is nothing but multiple strictures. What will be the clinical features in patients with primary sclerosing cholangitis? These bile salts and bile pigments, they accumulate within the skin. And you also have some opioid intermediate products or opioid products that will be accumulated in the skin, and that will make the individual to develop pleuritis. And these patients will have osteopenia due to vitamin D deficiency because the precursor of the vitamin D is synthesized in the liver. And how is that you will be testing for this? See, it is a marker of, it is a disorder of the obstruction. What are the markers for obstruction? Alkaline phosphatase levels are elevated and gamma GGT are being elevated. These two are the markers of the obstructive pathology which is being elevated, right? What is the investigation of choice? See, actually in primary biliary cholangitis, you can do biopsy. But here, the investigation of choice is MRCP, magnetic resonance cholangiopancreatography. Right? If you do liver biopsy, chalo, you will have onion skin appearance. Right? Then what is the treatment? You need to give ursodeoxycholic acid, which will slow down the progression of the liver pathology. And next important is you need to give or you need to do ERCP. But when will you do ERCP? If there is presence of large strictures which is causing severe symptomatic problem, in that you need to do ERCP. ERCP करके क्या करना है? You need to do balloon dilatation of the strictures. And followed by that, you need to do orthoptic liver transplantation when the individual has gone into a stage of end-stage liver disease, right? So that is about primary biliary cholangitis and primary sclerosing cholangitis. So the difference is primary biliary cholangitis, only intrahepatic bile duct problem, whereas primary sclerosing cholangitis, both intrahepatic and as well as extrahepatic biliary destruction. Okay, right. Regarding the jaundice, I'll not go into a detailed discussion. I'll tell you what are those 3 types of jaundice and what are the findings. That will be done regarding the jaundice. Okay, yes. Answer this question. The answer is C. Now, what are the 3 types of jaundice that can occur in adults? Hemolytic jaundice, hepatocellular jaundice, obstructive jaundice. You take the first scenario, that is in hemolytic jaundice. In hemolytic jaundice, the problem is before the liver. The problem is not within the liver. The problem is before the liver, where there is the excessive hemolysis, right? Where there is the excessive hemolysis. Now, in case of the hemolytic jaundice, the unconjugated, so the hemolytic jaundice, unconjugated bilirubin is being elevated because there is excessive hemolysis. And problem is not in the liver. That is the reason why SGOT, SGPT will remain normal. And even alkaline phosphatase levels also will be normal, because I have said you, alkaline phosphatase is a marker of the obstructive pathology in the liver. And in the hemolytic jaundice, is there any obstruction? No. It's like the alkaline phosphatase levels will be normal. So in hemolytic jaundice, it is only unconjugated bilirubin that will be elevated. SGOT, SGPT will be normal and alkaline phosphatase normal. Hepatocellular jaundice. Hepatocellular jaundice. In hepatocellular jaundice, the problem is within the liver. So bilirubin elevated, SGOT, SGPT elevated, alkaline phosphatase normal, or there may be mild rise, because in hepatocellular jaundice you don't have the problem of obstruction. That is the reason why alkaline phosphatase levels will remain normal. Obstructive jaundice, where there is an obstruction. So in any form of jaundice, definitely bilirubin is elevated. Only in case of hemolytic jaundice, unconjugated bilirubin will be elevated. But in hepatocellular and obstructive jaundice, the problem is within the liver and outside the liver. So the conjugated bilirubin will be elevated. And in obstructive jaundice, the problem is outside the liver, not within the liver. So that is the reason why SGOT, SGPT levels will remain normal. But what has been elevated? The alkaline phosphatase and as well as the gamma GGT, right? Gamma GGT, that will be elevated in case of the obstructive jaundice. So very simple to define, to make out the jaundice. Hemolytic jaundice, unconjugated bilirubin elevated, remaining everything normal. Hepatocellular jaundice, bilirubin elevated, conjugated, SGOT, SGPT elevated, alkaline phosphatase normal. Obstructive jaundice, conjugated bilirubin elevated, SGOT, SGPT normal, because the problem is outside the liver, and the obstructive pathology, that is alkaline phosphatase and gamma GGT, is elevated. So these 3 things, if you know related to the jaundice, that is more than enough, right? And if you want to have a detailed discussion of the jaundice, right, I have provided this in the PDF, and you can go through this in the PDF as well, right? Right. So as I have already said you, the PDFs are available on my Telegram channel, that is Medicine Made Easy by Dr. Rajesh Gubba. Now, the next topics for the discussion are the Wilson's and as well as the hemochromatosis. Chalo, answer this question, guys. Liver biopsy for copper will be stained by which of the following stain? Actually, it's an integration. Pearl stain, Rubianic stain, supravital stain, Schmoll's method. Very good. So for liver biopsy, for copper, the stain that we use is the Rubianic acid. That is Rubianic acid. Okay. Whereas the pearl stain, that is for the iron deposits. that is for iron deposits. And you take the supravital stain, that is used in microscopy to observe the cells of living organisms. Right, to observe the cells of living organisms, you need to do supravital staining. Next is the Schmoll's method. Schmoll's method is mainly to detect the melanine. Mainly to detect the melanine. Okay. So that is about, yeah, hemochromatosis, it is pulse. Hemochromatosis, it is pulse. Okay. Now, let us do the detailed discussion of Wilson's and as well as the hemochromatosis. So what is that very commonly asked in case of Wilson's? Gene mutation. What is the gene that is being mutated? The gene that is being mutated is the ATP7B gene that is being mutated, and on which chromosome it is present? It is present on chromosome number 13. And how is it being inherited? It is being inherited as the autosomal recessive type of inheritance. Now, because of this gene problem, what is being deficient? Ceruloplasmin is being deficient. And because the ceruloplasmin is being deficient, what is the problem? The copper will go and accumulate in various parts of our body. That is liver, brain, kidney, and as well as eyes. Multi-system involvement will be there in case of Wilson's. And accordingly, what will be the individual organ involvement? Okay. So liver problem is like hepatitis and cirrhosis of liver. Mainly in case of Wilson's, you will have macronodular cirrhosis. Right? So you will have macronodular cirrhosis. Neurological, your copper will go and accumulate within the basal ganglia or in the extrapyramidal systems. That is the reason why these patients will have tremors, dysarthria. Psychiatric manifestations in the form of emotional instability. The copper can also go and accumulate within the kidney, resulting in Fanconi's syndrome. What is Fanconi's? Anyone, guys? It is type 2 renal tubular acidosis. Within the eye, copper can accumulate, resulting in the KF ring, or the KF ring will be there within the Descemet's membrane of the cornea. How will you evaluate these patients? You need to do a first line investigation is 24-hour urinary copper. That will be more than 100 micrograms per day. Right, more than 100 micrograms per day. And what are the other investigations? Liver biopsy, if you do, the hepatic copper will be more than 250 micrograms per gram of dry weight. And ceruloplasmin levels are decreased. That is a problem in Wilson's due to the ATP7B gene mutation. MRI, face of panda sign. Genetic testing is the one which will confirm that it is Wilson's, where you have a problem in ATP7B, right? Now, can anyone tell me differential diagnosis for face of panda? So the face of panda is observed in case of the sarcoidosis. So in sarcoidosis, you will have this face of panda sign. That is in gallium uptake studies. I'm not talking about MRI head. In gallium uptake studies, you will have the face of panda sign in sarcoidosis. Okay? Then, how do you treat these patients with the Wilson's? So you need to give zinc acetate. What the zinc acetate will do? It will inhibit the copper absorption. What are the alternative molecules? The alternative molecules are trientine and as well as D-penicillamine. Trientine and D-penicillamine, they are given mainly in a state of the decompensated cases. Mainly in decompensated cases. Then next important is when the individual develops severe disease. Now this is a question here. What is the index that we use for Wilson's? That is Naser score. And if this Naser score is more than 9, that is the point when you need to do the orthooptic liver transplantation. Done? So this is about your Wilson's. So regarding Wilson's, what is the questions now? Gene, ATP7B gene. Which chromosome? Chromosome 13. Inheritance, autosomal recessive type of inheritance. What is the problem? Ceruloplasmin being deficient. What are the organs affected? That is liver, kidney, brain, eyes. Right? And accordingly, you have the manifestations. Type of cirrhosis, macronodular cirrhosis. Within the eye, KF ring. Within the kidney, Fanconi's syndrome. Within the brain, resting tremors and extrapyramidal side effects. Workup, 24-hour urinary copper. Confirmation by genetic testing. MRI head, face of panda sign. Treatment, zinc acetate. Mechanism, inhibits the copper reabsorption. Right? That is about the Wilson's. Next topic is the hemochromatosis. This is the last topic in the hepatology. This is the last topic in the hepatology. So, in case of the hemochromatosis, that is also again due to gene abnormality. What is the gene that is being defective? The HFE gene is being mutated, where there was ATP7B gene, which was present on chromosome 13. Whereas here, it is HFE gene, which is present on the chromosome 6. Type of inheritance, autosomal recessive type of inheritance. And because of this HFE gene mutation, what is the problem? The problem is there is unregulated iron absorption. There is excessive iron absorption, and that iron will go and accumulate within the liver, pancreas, heart, skin, and as well as the joints. And what is the organ that is affected first? That is liver. Liver is the first organ that is being affected. What is the first line investigation? You need to check the transferrin saturation. So what will happen to the transferrin saturation? That will be more than 45%, and that is the first line investigation. And you take this multi-system involvement. So liver involvement will be in the form of cirrhosis, but here it is micronodular cirrhosis in hemochromatosis, whereas in Wilson's it is macronodular cirrhosis, right? And regarding the pancreas, like bronze diabetes mellitus. Regarding the heart, there will be development of the cardiomyopathy, right? That is, what type of cardiomyopathy in hemochromatosis? Anyone? What type of cardiomyopathy you will have in hemochromatosis? So it is both. Restrictive cardiomyopathy can be there, and as well as dilated cardiomyopathy can also be there in case of the hemochromatosis, right? That is the heart. Skin, that will be in the form of hyperpigmented skin. Bronzing of the skin will be there. And which particular joints are affected? That is second and third metacarpophalangeal joints. And I said you, like, the first line investigation is what? That is, the transferrin saturation will be more than 45%. And the investigation of choice will be liver biopsy. Liver biopsy will show you that the hepatic iron index is more than 2. And how will you confirm the diagnosis? That is by genetic testing, where you will have the HFE mutation, right? And the first line treatment will be what? Phlebotomy. By doing phlebotomy, you will be taking out the excess iron. But if there is anemia, you cannot do phlebotomy. Whenever there is anemia, then what is that you need to do? You need to do the iron chelation. That is, iron chelation can be done with the deferoxamine and as well as deferoxyrox. Okay, so this is about the hemochromatosis. So what are the important points? Gene mutated is HFE gene mutation, which is present on the chromosome number 6. The first organ that is affected is liver. That will be in the form of your micronodular cirrhosis. And the first line investigation will be transferrin saturation. Investigation of choice will be liver biopsy, and first line treatment will be phlebotomy. So this is about the story related to the hemochromatosis, and this is the story related to the hepatology as well. Yes, please tell me, how was the session until hepatology? Yes, how was the session until hepatology?